Use of the hamstring tendons for anterior cruciate ligament reconstruction is well established in orthopedic surgery, especially in the recreational athlete. When compared with patella tendon grafts, the lesser amount of operative pain and morbidity allows for more rapid rehabilitation, making this a very attractive procedure while at the same time achieving comparable results. Success is predicated on the firm fixation of the reconstructed graft in the femoral and tibial tunnels. On the femoral side, this can be achieved with a transfix pin, which serves as a firm anchor for the looped, closed ends of the quadruple tendon. On the tibial side, the free ends of the quadruple tendon graft can be secured with an interference screw, giving very firm fixation. The position for the tibial tunnel is referenced with the root of the posterior cruciate ligament shown here. Thus, moving forward 1 millimeter for the posterior aspect of the tibial tunnel, and then adding another 4 millimeters for the radius of the graft, we find the isometric point approximately here. The anterior cruciate guide, set at 65 degrees, is inserted through the anterior medial portal. In this particular case, we have an 8.5 millimeter graft. We'll drill an 8 millimeter hole dilated to 8.5 millimeters. A radius half of that is 4.25 millimeters or 4 millimeters. We'll add another millimeter for the posterior aspect of the tibial tunnel, so we'll measure 5 millimeters anterior to the posterior cruciate ligament. The guide wire is advanced into view so that we can be assured that it has not been misdirected within the tibia. Over-drilling is then accomplished with a cannulated 8 millimeter drill, and then the tunnel will be dilated to 8.5 millimeters. One of a series of the over-the-top guides is now utilized to reference off the over-the-top position anteriorly. In this case, we have a left knee. We will use the 130 position. The graft will measure 5 millimeters anteriorly, giving us 1 millimeter for the posterior wall, 4 millimeters for the radius of the hole, placing it in the isometric, or as near the isometric position as possible. Drilling is carried out through the femur all the way through the lateral femoral cortex for proper fixation. Drilling is then carried out to a depth of 40 millimeters in most individuals. In shorter individuals, a tunnel of 35 millimeters in length may be necessary because of the short length of the tendons involved. This individual requires an 8.5 millimeter tunnel, so we'll dilate our tunnel from 8 to 8.5 millimeters. The aim is to achieve a tunnel which is snug, but not too tight to allow passage of the tendons easily. The orifice of the tibial tunnel is then prepared for the free ends of the tendon graft. A notch is made in each quadrant to accept individual graft strands. The quad notcher is inserted to the depth markers. The result is a round tunnel with notches inferiorly, superiorly, laterally, and medially for the 4 free strands of the quadruple tendon. The transfix pin guide is then inserted into the tibial tunnel. It transgresses the intra-articular space and then is thrust into the femoral tunnel to a depth of 30 millimeters. The femoral tunnel is drilled to 40 millimeters to accommodate for 30 millimeters of the graft, plus an additional 10 millimeters for the mass of the graft looped over the implant. The cannulated guide is advanced against the skin over the lateral aspect of the thigh to mark the insertion site. The reference point is the medial femoral condyle. The aim is to insert this pin horizontally and therefore avoid any damage which might occur to the more posterior lying saphenous nerve or the femoral artery. A puncture wound is made through the skin and down through the iliotibial band to the femur. The guide inserted until it impinges against the femur itself. A Beath needle is then inserted into the cannulated guide and driven across the knee. This will transgress the lateral femoral cortex, then the femoral tunnel with the eye of the transfix guide, before finally penetrating the medial cortex of the femur and exiting through the skin on the medial aspect of the knee. The cannulated guide is then removed, as is the sidearm. The lateral cortex of the femur is then broached to accommodate the head of the transfix pin. The guide is now captured by the transfix pin, as demonstrated here. A nitinol wire is then attached to the end of the Beath needle. The nitinol wire is then advanced across the knee along the course of the Beath needle. The sidearm is then reapplied to the guide to create a handle for ease of extraction. The guide is then removed from the knee, delivering the nitinol wire. The graft is brought from the back table and looped through the wire.
Care is made that the two ends of the semitendinosus tendon are the same length, and similarly that the two ends of the shorter gracilis tendon are of the same length. The graft is then advanced into the knee by simply pulling on the clamps which have previously been placed on the ends of the nitinol wire. One can be assured that the graft has reached the apex of the femoral tunnel by the ease of the to and fro movement of the nitinol wire. To facilitate implantation of the transfixed pin, a tap is first utilized. This comes with a collar which will abut against the lateral femoral condyle, determining appropriate depth of insertion. To assure that the tap is directed properly, tension is placed on the nitinol wire, one clamp attached proximally, the second being grasped and pulled medially. The tap is then advanced until the collar abuts on the lateral femoral cortex. Before the transfixed pin is inserted, the depth from the skin to the femoral cortex is measured with the impaction device. In this case, 28 millimeters is noted. The transfixed pin is then inserted over the wire. The cannulated impaction device similarly is inserted over the wire, and once again a clamp attached proximally. Tension will be applied to the wire, once again assuring that the transfixed pin transgresses the femur in the preordained direction. The pin will then be impacted to the depth of 28 millimeters. This will assure that impaction occurs to the proper depth and that the head of the transfixed pin does not remain proud, or that the pin is not driven excessively into the depth of the femur, a potential problem in women with osteoporosis. Before the impaction device is removed, we assure ourselves that no kinking has occurred by gently moving the nitinol wire to and fro. The impaction device is removed, the nitinol wire extracted, and the graft ends are then pulled into the previously prepared notches. The larger grafts placed anteriorly and posteriorly, the smaller graft, that is the ends of the gracilis tendon, laterally and medially. This gives each tendon a niche, which increases the surface area for ingrowth, but also prevents capture by the screw, which otherwise might wad these tendons into a ball in one corner of the tunnel. Next, a series of dilators is inserted between the graft ends. Before we determine that this is a snug fit and that a screw of 9 plus 2 millimeters, that is 11 millimeters, will be appropriate for insertion. In this particular case, 11 by 35 millimeter screw is utilized. I prefer a 35 millimeter screw for longer length and therefore greater purchase. The tendon ends are held under moderate tension, and an interference screw is then inserted with the power drill. The dial indicates 16 inch-pounds of torque, which correlates with the fixation strength necessary for early postoperative rehabilitation. As you will note, the tendon ends remain within their notches, but the screw is inset into the tibia so that nothing remains proud. The tendon is now fixed top and bottom. All implants are biodegradable, an important feature if revision would be required at a later date. The superfluous portion of the tendon ends are then transected and closure undertaken in a typical fashion. The interarticular portion of the graft is now visualized, noted to exit from the femur, to enter the tibia, to cross snugly against the posterior cruciate ligament, and to be free of impingement from the lateral wall of the femur or the intercondylar notch.